So, to make it very short, the question was definition. I think we simply don't know. Next one was how was the natural cause of the pain after a herniorrhaphy? So that means that you have the operation here. Some patients have pain before or should have pain because that is the indication for surgery. Then you have acute pain, and we hope that it goes down. But in some patients, it may come up again. In other patients, it may just continue to be a chronic pain state. And I will go a little into detail with that and then end up also to discuss what happens years after the operations with this chronic pain state. And I think you asked a question before, what was the relationship between the acute postoperative pain response to the chronic pain response? And this study we did some years ago in a large consecutive, very well-defined group of patients undergoing primary inguinal hernia repair with multimodal, well-defined, evidence-based analgesia. And we followed all these patients 1 year later. And overall in this series, 6% of the patients had chronic pain influencing daily life in a very, very detailed assessment. Then we wanted to correlate the chronic pain state to what the patients had of acute pain, very detailed assessed within the first 7 days. And the patients didn't know what they had because we had kept that secret on the records after the operation. So those patients with low acute pain, there was only 3% of those who ended up to have a chronic pain state. But those with high acute pain scores, there was a 3-fold higher risk of ending up with a chronic pain state. And interestingly, when we did the same analysis, but now based upon the detailed assessment of pain during functions 4 weeks postoperatively and correlated to the pain intensity and the consequences 1 year later, you can see that those with low acute pain scores at 4 weeks, they still had a very low risk of chronic pain. But those who had high acute pain scores at 4 weeks postoperatively, 1 out of 4 ended up having a chronic pain state. So that shows that there is a transition. The question is really, what about, as Reinhold discussed, and also Parte2 has data on how many patients are pain-free for some time postoperatively and then end up with a chronic pain state. I think we need much more detailed studies here where we look at the patients and not only the questionnaires. The burnout rate has been assessed in the study you saw from Parte2 in his laparoscopic versus open. It decreased with time, but interestingly, numbness didn't change. We took all our Danish chronic pain patients analyzed across the country. It was more than 1,000 patients. There was 11% in that sample who had pain influencing daily function. And then we looked at the same group 6 years later, 6 years after the operation, and there was about a 50% reduction of chronic pain influencing daily life. Some of the patients had less pain, but still chronic pain. Some of them got much worse. So there is a difference, but overall there is a burnout of chronic pain in these patients. So the questions I got, the ISP definition for chronic pain is 3 months after an injury. But these people have never thought about chronic post-operative pain. They have thought about some other chronic pain states. So I think because we implant these meshes and have inflammation, that we should probably go up to 6 months before we say it is a chronic pain state. You have to consider also when you discuss the choice of your treatment that there is a considerable burnout. This is important. Also when you assess your surgical treatments versus the pharmacological treatments, remember that there is a burnout, and this will probably be in the range of 50%. New chronic pain cases after an initial pain-free state, I think that we don't have the answer. It is probably in the range of 30, 50, or maybe even higher from your data, but I think we need more detailed studies where we have a clinical assessment of these patients. Finally, I was asked, and Amit will discuss that in much more detail, up to 2005, when we analyzed all the literature on surgical management of chronic pain, we concluded that there was insufficient methodology in all studies. Follow-up, there was not well defined. There was no QST. There was no neurophysiological assessment of anything. There was different types of assessment. Most often it was a yes or no question to chronic pain, which is totally insufficient. And at that time, before Amit published his very large series we will hear about, we concluded that neurorectomy could not be recommended for routine treatment until we have further studies. And furthermore, what is surgical treatment? There are maybe different approaches in different types of pain patients. It could be a removal of a mesh, for instance, a plug. It could be an open neurorectomy, as we will hear about. But it could also be a laparoscopic neurorectomy where you approach the nerves from behind, which in some way may make more sense because it may be more well-defined and may be more easy, but we don't know. So to conclude here, results of pharmacological treatment with all the different approaches that Mike told you about, we simply do not have any series in hernia patients. And again, remember, the hernia chronic pain patients, that is probably a mixture of inflammatory and neuropathic pain. So we have to find out which type of patients will respond to which type of pharmacological treatment. This is important, and we don't know. Surgical treatment, in my opinion, should only be considered at least 1 year post-operatively, and when the pain intensity is so severe that it decreases your social life, and it must be assessed in detail to what extent, and also when conventional treatment has failed. But there may be a subgroup with acute neuropathic pain. There is no data in the literature, but I think we all know, seen these patients with severe acute pain after, for instance, a laparoscopic operation, where the pain otherwise is not so big after the operation, and they have sensory disturbances and severe acute pain. These patients should probably be operated acute to remove the responsible thing. That may be a target or a stapler or so. But finally, and this is probably the most important message, I think we have to go together, a few groups who have enough patients in a multi-center, same protocol collaboration to define the indication for surgery and the treatment approach. Because no single clinic, except for very few like Los Angeles, will be able to collect these patients to a major extent. The last question was easy. Method of follow-up must be physical examination. It must include detailed neurophysiology to understand what is going on. Must be done. What is the time of the follow-up? Indefinite. Indefinite. Because we need to know the natural cause. There are so many papers on surgical treatment for pain states. I think you will agree, Mike. They always help in the beginning, but when you wait, they have pain again, or maybe even worse in the long run. So chronic post-herniorrhaphy pain is difficult. It is very difficult because there are so many pathogenic factors, and not a single study, prospective, have analyzed that before. Within half a year, we will have all this in about 800 patients with gene analysis, preoperative QST, psychology, etc., etc. The inclusion has been made, and all patients have been with a 6 months follow-up now. So preoperative pain intensity, we know that correlates to chronic pain. Psychological factors may not be that important in this operation compared to chronic pain after mastectomy or lung cancer surgery. The type of surgical trauma we heard, laparoscopic versus open, is important. Nerve injury is definitely important, but we cannot really separate it from the inflammatory response. We know that acute post-op pain correlates to chronic pain, but that doesn't mean that if you treat acute pain that you reduce the risk of chronic pain. No study has ever shown that. It is probably here. we have some genetic things going on to determine your acute pain responses as well as chronic pain responses. And all this we have to know before we really know what to do in these patients, and especially to prevent it. Thank you very much.